Welcome, people who've just joined in the last 30 seconds as well. My name is Alan Higgins. I'm the Health Equity Network lead, and we're delighted to have this bonus webinar this month, which is on the World Health Organization World Report on Social Determinants of Health Equity. And I'll just mute that for a second. We're delighted to have Sudhvir Singh, who is head of the Equity and Health Unit at WHO. And Sudhvir is here to talk about the headline findings on the global perspective on tackling the structural drivers of health inequality, which is in the World Report. And we'll also then have Jessica Allen, who's the Deputy Director at IHE, and Antia, Castedo, who's one of our senior researchers, who will talk about and reflect on the evidence base and how it links to the work in the UK through Marmot places as well. And then we will have Sir Michael Marmot, who will give us his overall reflections and implications of the World Report. After that, we will open up for questions. And as usual, if you want to start posting questions in the chat, then please do so. I will then come back to you and invite you to come on and ask the questions at the appropriate time. So, if we're all good to go, I will invite Sudhvir to come on screen and start the presentation. And I think Jamaica is showing slides. Sudhvir.
Great. Thanks so much, Alan, and wonderful to see you all. Really great to be part of one of your network meetings. I'm really impressed by the scale and activity of the network. I managed to join a couple of the meetings, and it's very concrete what's happening and what's being shared, and it's exciting to be part of your movement. So thanks for joining today. I think it's really great also that we have colleagues from IHE speaking after me, because they've been fundamental to this report being finished, being robust in terms of its evidence, and being out in the world. So I'm looking forward to their reflections. But yes, it's a very detailed report. It's over 200 pages, and I've just got a few minutes, so I'll keep this at a high-level summary. But please feel free to read the report. We'll make sure you have access to it. And we have a range of materials, policy briefs, executive summaries, etc., that we can make available to the network. But just to start with, why this report and why now? Well, at the peak of the COVID-19 pandemic, that the impacts were deeply inequitable, both between and within countries, and that pre-existing inequities were making the pandemic worse. So against that backdrop, our member states came together at the World Health Assembly in 2021 and endorsed a resolution on the social determinants of health. This requested an updated world report from WHO that summarizes the latest evidence and puts forward concrete recommendations to reduce health inequities. So this report comes at the request of governments for WHO to support greater action on the social determinants of health. If we go to the next slide, please. The resolution asked WHO specifically to build on the previous global report, which was the landmark Commission on the Social Determinants of Health final report, which was published in 2008. And of course, the commission was chaired by Professor Sir Michael Marmot, who I'm very pleased is with us here today and has been very instrumental in the World Report as well. So the commission aimed to close the gap in a generation and set targets to be achieved by the year 2040. And in the first chapter of the World Report, we look at the progress against those targets. So if we go to the next slide, please. To begin with, we look at life expectancy at birth from the year 2000. And here you can see that there's been some progress in narrowing the between country gap in life expectancy through a leveling up of the bottom third of countries, that purple line. But unfortunately, the progress is at an insufficient rate to meet the targets you see on the right there in red. So some progress, but at an insufficient rate. If we go to the next slide. Here we look at child mortality rates by country income group. The global average is the dark blue line in the middle. And there you can see there's been a halving of child mortality. But you can see that the lines are beginning to flatten out. So progress is slowing. And still today, a child born in a low-income country has 13 times the chance of dying before the age of 5 compared to a child born in a high-income country. If you go to the next slide, please. Here we have maternal mortality rates. It's a similar picture. There's been a 40% reduction, but here we can see the impacts of the COVID-19 pandemic causing a spike in all groups of countries, and we're still a long way off achieving the target. Next slide, please. So in summary, there's a huge amount of data in the report, but some of the key messages are that there's been some progress towards closing health gaps between countries, but that progress is unfortunately stalling. And what's really worrying, though, is that when we look at what's happening to health inequities between social groups within countries, the gaps often appear to be widening. And that's whether we look at comparisons of people based on their income or their education level or ethnicity, race, where we have data, and unfortunately in many places we are lacking data, but we are seeing some backsliding on health inequities. And of course that includes the UK as well, which has been well documented by IHE and other groups. So if we go to the next slide. So why might that be? Well, the report looks at some key data and trends across social determinants. Some of the highlights include the fact that income inequality within countries is increasing. We're seeing wealth being more and more concentrated. At the same time, fiscal space is reducing. Tax systems are often underperforming, leaving 3.8 billion people around the world without any social protection coverage. Debt distress is intensifying. Interest costs on debt have quadrupled for the world's poorest countries over the past decade. So that's no recipe for investing in the social determinants of health. At the same time, climate change and conflict are directly impacting on health and intensifying. 2024 had the most conflict in the world since the Second World War, and it was also the hottest year in the world on record. And we know that people living in conflict settings have the worst health outcomes. So together, this has resulted in a tripling of forced displacement in the last 15 years. So if we go to the next slide, please. So what is the diagnosis, and most importantly, what can we do about it? Well, the second chapter of the report presents a framework for understanding the drivers leading to poor health and health inequity, building on the Commission's original framework. We start on the left there with economic systems, including tax, the way markets operate, the commercial determinants of health. We look at social infrastructure, which we say are the policies, services, and places that allow people to fully participate in their societies, and how societies have to adapt to forces like urbanization and demographic shifts. We recognize that too often discrimination is deeply embedded in our institutions, in our norms and policies, including the intersection of structural racism with gender inequality, but also discrimination based on class, based on sexual orientation, age, or whether or not you have a disability. We've talked already about the grave health impacts of conflict, and we also observe about how the world is being fundamentally reshaped by megatrends like climate change and digitalization. So the report puts forward that unless we recognize and address these underlying structures and trends, we will always be playing catch up when it comes to improving health equity and population health. So then the second part of chapter 2 then goes on to describe how these structural determinants directly shape the living conditions that are the building blocks of health, whether that's education, work, the types of food, housing, transport, and energy we have access to, as well as more recently recognized areas in public health like social isolation and social connection. The remainder of the report, after the chapter 2, focuses on the evidence behind concrete actions to address these structural determinants and how we can learn from and be inspired by actions that are already taking place all over the world. So if we go to the next slide, please. So the first chapter of recommendations talks directly about the importance of addressing economic inequality and investing in universal public services. So the report speaks to the importance of progressive taxation, where the wealthier pay proportionally more to allow investment in universal public services. We call for health equity to be central in international discussions on tax loopholes, debt distress, and trade processes. We focus on the need to address the commercial determinants of health. This is relatively new coming from WHO, but this involves regulating health harming commercial activities, including the role of health taxes, but also how we can maximize the health promoting capacity of the private sector. And I know there's been wonderful examples of this shared in the network and with the collaboration with Legal in General. We also look at the need to expand social protection coverage across the life course, such as sick leave and child benefits. If we go to the next slide, please. The next chapter looks at what can be done to recognize and repair structural discrimination. This includes recognizing and redressing the health impacts of historical injustices and upholding the rights of Indigenous peoples. We also call for social determinants of health to be protected in emergency and conflict settings. If we go to the next slide, please. The next chapter then zooms in on how megatrends can be steered towards health equity, how we can accelerate climate action and ensure that while we decarbonize, we address energy poverty, we address food insecurity, and how we have to make good on the immense promise of digitalization for better social and health outcomes by putting equity at the center of the digital transformation and by managing harmful impacts, whether that's in the information environment, we're seeing threats to social cohesion, or cyberbullying, or precarious gig work, putting livelihoods at risk. If we go to the next slide, please. So bringing this all together, the report then looks at how we can govern and make decisions in the interest of health equity. We start with the core importance of action at the local level and equipping local government with the mandate and resources to take action for health equity in areas like housing and transport and urban planning. And in the last session of the network, I was very inspired to see the work of the Marmot Places, which very much embodies this approach. We talk about the central role of communities and civil society and ensure that those who are most affected can be at the center of decision making. The report also recognizes the importance of achieving universal health coverage, ensuring equitable access to a full range of physical and mental health services. And to do this, we need a well-capacitated and well-supported health and care workforce, which walks the talk on equity itself, addressing discrimination within our own ranks, for example, in the care economy, and also having the capacity to collaborate and work together across sectors for health equity. We look at the need for data and monitoring to inform policy action. And finally, the report concludes with a call to action, emphasizing that health equity needs to be a central focus, not just of health systems, but of governments as a whole. If you go to the next slide, please. So to conclude with, I haven't been able to do justice to the scale of the report and the process involved. Here on this slide, you can just see some examples of some key numbers. But there's been a huge amount of work behind the report, a number of evidence reviews, including an important one that we'll hear more about from UCL colleagues. There's been hundreds of staff from WHO involved. I see some of them actually on the call. Hi, April from the Philippines, for example. But we've really drawn on a lot of technical expertise from WHO. We've been guided by researchers and policy advisors from all over the world. Our member states have also been involved and showed actually a lot of support for the bold nature of the recommendations when they were presented at last year's World Health Assembly. And we also engaged substantively with communities and civil society groups, and we learned a lot from them. And I see Felicity Porritt on the call, who's been instrumental in those consultations. And we really look forward to working with everyone on the call here to now take forward these recommendations and to build a future where we can all enjoy the benefits of health equity. If you go to my final slide, please. Just to say as an example of the momentum since the launch last week, we're really thrilled that next week there's going to be a high-level side event at the World Health Assembly. Anyone here is welcome to join. And if you look there, there's just so many countries that are stepping up and saying this is important, especially in this time of major challenges in the multilateral space, major challenges in research and health equity. So it's great that countries like Peru, Chile, South Africa, Japan, Brazil, Spain. We've just had Thailand joining us at this event and putting forward high-level speakers to talk about the importance of this work and now taking forward action on the social determinants of health to reduce health inequities. So I'll share more information about that event. If anyone's in Geneva next week, you're more than welcome. So Alan, I'll stop there. Looking forward to the discussion and to my fellow speakers on the panel here. Thanks so much.
Thank you, Sudhvir. That was excellent. Thanks for such a succinct summary of an enormous report dealing with, well, mega issues. I think they were highlighted, or mega trends were highlighted in one of your slides. Thank you so much for that. That's great to get us underway. There'll be comments in the chat that you may want to refer back to that we'll bring in after the presentations. So is it Jessica next or Antia? Jessica?
Antia. I think I'm going first and then Jessica.
Go ahead, Antia.
Thank you, Alan. I have one slide, but if we can just wait a second before we put it up. Thank you. My name is Antia Castedo, and I'm a senior researcher at the IHE. I was part of the team that worked on the evidence review that we produced to support the evidence base of the recommendations of this work report. And I was asked to reflect a bit on this work and on the evidence base for the report. And I just thought it was a good idea to start with my personal experience. I was a junior researcher at the time of the Commission on the Social Determinants of Health, working in one of the 9 knowledge networks that were tasked by the Commission to gather evidence on the social determinants. At the time, it was considered crucial to gather as much evidence as possible on the link between these social determinants and health inequalities. And this is what the knowledge networks were meant to do. So at the Employment Conditions Knowledge Network, where I was working, we spent a lot of time gathering and reviewing evidence on the link between different employment conditions, such as precarious employment, on informal work, and health inequalities. Other colleagues in other knowledge networks were doing similar things. So people were working on things like early childhood development, or were working on globalization, urbanization, monitoring and evaluation. So things that were considered crucial. In fact, I was reviewing this morning the final report of the Commission on the Social Determinants of Health, and the report itself is asking for more evidence. It's saying that more research is needed. And I think maybe Sir Michael can talk about this a little bit later, but I don't think the Commission people were thinking that at the time there wasn't enough evidence to support the recommendations of the Commission. But it was more of a call for academics and institutions to do more work on proving those links, in particular between the structural determinants of health inequalities, which needed more work at the time. Fast forward several years, and we have this chart that maybe we can put up with the slide, Jamaica or Alan, if you can see it. Yep. So it's a very simple chart. I hope you can see it. It's showing the number of articles published each year from 2005 on the social determinants of health as they appear on the search engine PubMed. And we can see that, for example, in 2012, there were 1,000 articles. In 2015, there were over 2,000 articles. In 2018, there were more than 3,000 articles. In 2020, which was the first year of the COVID-19 pandemic, there were more than 5,000 articles. And last year, there were more than 7,000. So this is a very simple exercise, but I think the message is that it would be very hard today for anyone to say that we don't know enough about this. And hence, this WHO report is focusing more on making recommendations. So at the IHE, we were asked to review the evidence regarding these recommendations, and in particular to focus on systematic review and meta-analysis, evidence coming from systematic reviews. And we did find a lot of systematic reviews. In fact, our evidence review has over 300 sources, I think. And we have articles on everything from the impact of taxation on health, or, for example, other things such as the commercial determinants, like Sudhvir was saying, or the impact of minimum wages. Where we did not find systematic reviews, there were mostly, generally, also very good individual articles on longitudinal or cross-sectional. So the evidence base has grown, and we have really come a long way since the time of the Commission, not only on knowing about the pathways and mechanisms linking these social determinants with health inequalities, but also we know much more now about which interventions are more effective. So that's the positive note. But obviously, there are also some gaps, like Sudhvir was saying. One of the things that we noticed when working on this review was that a lot of the evidence still is coming from the global north, in particular from the United States. And as things stand at the moment, this might change in the coming years, but now it's the way it is. So we definitely need more evidence coming from the global south. However, I think personally that we also need to be better at incorporating the knowledge that already exists in the global south, and which perhaps is not being disseminated in the channels that we usually use. Sometimes we think that because there is no evidence published in English in some of the most known journals, it means that there is no evidence at all, and that's not true. So this is, I think, something in which we can still become better. Some areas which were possibly in its infancy at the time of the Commission, like AI and digitalization, are becoming more and more important. And we need to know much more on how they are affecting inequalities in the labor markets, for example, how are algorithms impacting the health of platform workers, and things like this. I mean, there is some evidence. The World Report has some evidence on this, but there is much more that we need to be done. Some other areas, such as climate change, impossible to ignore, obviously. However, the impact of climate change on health inequalities also needs to be studied further. We were recently working on a report on environmental determinants of health in Hong Kong and looking at the impact of climate change, and there wasn't much evidence on the impact of climate change on health inequalities. So I think, you know, it's an example of an area where lots of work still can be done. So I think, you know, WHO has a crucial role to play in all this. This report is very welcome. We're honored to have worked on it. And as I say, there has been lots of progress done, but with everything else, lots still needs to be done. Thank you.
Brilliant. Thanks very much, Antia. And really good of your reminders just how robust and the breadth of the evidence that there is supporting the analysis and also the recommendations within the report. Jessica, would you like to pick up?
Yeah, just a couple of remarks from me. Thanks, Alan. Thanks, Antia and Sudhvir. As outlined, I think we can be pretty confident with some of the caveats and gaps Antia pointed out that there is a robust, very robust evidence base now on the social determinants of health and increasingly about what to do. I do think there's probably a gap in the evidence around how to take action, where to start, what to do, what are the practical steps, and so on around that. Just before I get into where that evidence base is emerging, though, just to point out that if we're often asked, we don't have enough evidence for this, where's the evidence for this? And sometimes I've begun to think that this is just being put up as an objection to taking action because of the politics, the complexity, the vested interests involved, which are barriers to action on the social determinants of health. So I'm just mentioning that because evidence can be used as a way to stop action, and it shouldn't be. There is enough. I think we can be confident. In relation to the relative evidence gap around how to take action, I just refer to two areas where that evidence is developing quite fast. One is the WHO's Special Initiative for Multi-Country Action on the Social Determinants of Health Equity, which does have an acronym CIMASH, which involves partner countries from the Americas, the Eastern Mediterranean region, and the Western Pacific regions, WHO regions. And they're really pushing, they're developing action at local level, often starting at local level and learning the lessons about what it takes to develop the systems needed to take action on the social determinants of health. So there's a lot of knowledge emerging from that programme now, which I hope will become well disseminated and articulated so that we can all learn about exactly how places and regions can take action. And also related to taking action, as many of you know, many of you are involved in, there's been a lot happening across the UK that we've been involved in and outside of our direct involvement as well. Over 50 local places and regions, towns, all taking action despite, you know, the relative lack of national focus on these issues. So that's been very encouraging, and we are learning a lot from those local places. And we understand that there's action happening in relation to the social determinants of health, so those Marmot 8 principles, to culture shifts and organisational change, to partnerships, to power shifts, so that kind of system development. And then thirdly, in relation to the processes and how to operationalise the approaches that we've been pushing forward through the social determinants of health. So things like accountability, resource allocations, and governance systems, really trying to embed the social determinants of health in the operational systems. So there's a lot of learning from that. We will be producing a stock take on what we feel we've learned and what places are telling us has happened through that programme. And just to mention also, we work with a number of national organisations in different sectors, with the healthcare system, with the community and voluntary sector organisations, with other public services. And again, we're learning a lot about what it takes within those big organisations in the UK to actually take action and begin to really implement the programmes. So more evidence around that will be emerging. And we hope very much that also from other parts of the world and from other organisations also taking action on the social determinants of health. Thank you, Alan.
Thank you very much, Jessie. Particularly important to mention the evidence and the learning that we're gathering around implementation, and also just the references you've made there. And you do get this sense of there being this international, worldwide movement for health equity. So I'd like to invite Sir Michael Marmot to give his reflections on the report and the implications, particularly of the recommendations. Michael.
I'm sorry if my camera still seems not to be working. I can see myself and I can see you. What I can also see is my computer is 10 years old and I'm about to replace it. So next time. When WHO launched the Commission on Social Determinants of Health report in 2008, we said we wanted to create a social movement. I would say our health equity network is part of that social movement. The fact that 3 of the regions at WHO did reviews on social determinants and health equity, the special initiative to which Jessica made reference. The evidence base that Antia summarized for us, the remarkable growth in publication. And I'm delighted to say WHO once again showing leadership by producing this report. Sudhvir presented it beautifully, a big report that he summarized. The fact that there will be a side event at the World Health Assembly next week with many countries involved, all part of the social movement. From time to time, when I'm in a meeting, I hear somebody say, "Oh, we've heard all this before. You know, we could have been having the same conversation years ago." And I have a flight or fight reaction when I hear that. And my cortisol rises, my sympathetic stress reaction goes into action. Because my response is, even if we had nothing new to say, it's important to say it again. In case people forget how important action on social determinants in health equity are, even if we have nothing new to say. But the second thing is, we have a great deal that is new to say. As Sudhvir summarized with the evidence, Antia talked about how much evidence went into the review. There's a great deal new to say. And when we look at progress on the three areas of the recommendations in the original WHO Commission report, improving knowledge and the evidence base for workforce, there's most definitely been progress there. Taking action on conditions of daily life and on the structural values, a mixed picture. What Sudhvir presented, it was real progress in reducing inequalities between countries in life expectancy, in adult mortality, in child health, in maternal mortality, real progress, but a great deal more to do. So if anybody says to me, we've heard all this before, hang on a minute, mate. Yes, we've made progress, but there's a great deal more to do. And particularly, and this is where this report excels, in addressing the structural drivers. And if people say, oh, it's all too complicated, we're dealing with these huge structural inequalities within countries, between countries, it's all too complicated. But the report says, no, it's not. It's not too complicated. We know we can break it down into areas on which we can act. And there's evidence that action has taken place with good effect, and areas where action can take place with, we think, good effect. And it comes back to, if you're, like me, stupid enough to read the newspaper on a daily basis, I wish I could wean myself from this habit, but there I am looking at the New York Times. As I wrote somewhere, quoting somebody, if you want to know what's happening in the world, read the New York Times. If you want to know what's wrong with what's happening in the world, read The Guardian. And if you want to know what's going to happen, read The Economist. Well, I tend to look at all three. I'm not sure it makes any positive impact on me. But what we are all saying, when I say we are part of this social movement, is that health equity is a value. It's something towards which we can all strive. That every time we see that ghastly news, and wars in various parts of the world, leaders who seem to have no values at all, and what we are all striving for is the value of a fair distribution of health between and within countries. And when I talk to colleagues who are suffering from the news, from what's actually happening, I talk about that yesterday I was in Medway. The day before I was in Camden and Kings Lynn and West Norfolk. And the enthusiasm and the vitality of people acting to improve the lives of their population. We can do it. We don't have to be swamped by the ghastly news that affects us every day. We've got an evidence base. We've got people who are committed to making a difference with values that we refer. And what this report is showing us is practical steps that can be taken. So thank you, Sudhvir. Thank you, Colin.
Thank you very much, Michael. And as a public health practitioner for many years, I can vouch for the feeling of being overwhelmed at times by the breadth of the analysis and the extent of the problems. And it is essential to be reminded of the possibility of making progress, and that others have done it and that we can do it too. And that breaking that overwhelming sense down into actionable points is a way of supporting each other, but also in actually getting on with the work. Thank you very much, Michael, for making that point. Before I go into the questions, we have about 4 lined up, I think. I'll just remind people that this is being recorded, that the webinar will be on the Health Equity Network probably by this afternoon, and that the slides will also be available through that route as well. Also a reminder, you can post questions in the chat. You can also use the hand facility at the top of the screen if you want to come in with a question. But we'll go back with to Linda Pasqui. Linda, would you like to come on screen and make the point that you were making earlier? And we'll pick up responses to that.
Yes, thank you very much to everyone. I got all your amazing exposition, data, and all the rest. My point is the underrepresented of a marginalized group. I'm a part of one of them. The initial report has been critiqued for non-adequately addressing the needs of a specific marginalized population, such as individuals with energy limiting disability, like HEN, CFS, long sickness, long COVID. This group face unique barriers to health equality in front of a nurse, maternity period, GP, workplace, HR. I smile because when the door are closed, it's very painful. I think we are not sufficiently recognized, and our voice is no address in the current framework. I think that is to do also with the fact that the original report offered limited guidance on how different countries can scale up successful policy, especially in low resource settings. So my question is, there is space, there is time to include also us, please. Thank you.
Thank you very much, Linda. So the question is about underrepresentation of marginalised groups in the report, and also lack of guidance about how countries across the world can move forward. Who would like to respond first?
I understood that there have been.
Linda, if you hang on for a second, we'll just see if we can get a response to your question.
Thank you. Thank you so much.
Thank you. Sudhvir?
Sure. Thanks, Linda, for the great question. And I think you raised some really important points, and we couldn't do justice to as much as we would have liked in the report. We had various limitations. It's a very big canvas, this agenda, and we couldn't zoom into the challenges different groups experiencing marginalization in as much detail as we would have liked. I can reassure you that we definitely consider ableism a form of discrimination. The report has many call-out boxes on the challenges facing persons with disabilities, and some of the solutions are also focused on that, whether it's, for example, the prime concept of accessibility in planning, amongst many factors. But one reassurance is that we work very closely with our colleagues who work on the rights of people living with disabilities, and they've produced a standalone global report, which I can put in the chat. But that went into much more detail from a WHO perspective on health equity for persons with disabilities. We're very much aligned in terms of our approach to the evidence and the recommendations. They also talk about structural factors, about determinants, about risk factors, and the need for a health system response that addresses barriers, addresses stigma, and we're very much aligned. So I'll put that report in the chat. That goes into much more detail. But yes, I think you raised some very important points. Thanks.
Thank you very much, Sudhvir. I really appreciate your answer, but I still say that no under categories, 3 principal categories, because a lot of people don't declare their stage long COVID because they would want be stigmatized. Thank you.
Thank you very much, Linda. Would anyone else like to pick up those points? Otherwise, I'll move on to another question. And given our shortage of time, I'll move on. Roisin Hurst, would you like to come on and raise a point that I think was very well made? Go ahead.
Yeah, I'm not sure if anyone will have an answer to this, but obviously in the presentation, Sudhvir, you referenced the fact that, you know, the world is in conflict more now than ever since the Second World War. And it does feel really overwhelming. And it's really a question about how do we even begin to tackle the social determinants that have a bearing on health in conflict situations when we see what's happening, you know, in Gaza, Israel's actions in Gaza, where there's a risk of a whole population either starving to death or being forcibly displaced, and also Putin's actions in Ukraine.
Thanks, Roisin. Big questions there. Sudhvir, Michael, Jessica, or Antia, would you like to respond? Go ahead, Michael.
It may sound a bit naive, but I think our voice has to be heard. We talk a great deal that conflict and political instability are social determinants of health. That any child, person, civilian who dies in conflict is an absolute tragedy. And the conflicts that you've just mentioned, absolutely tragic. And our voices have to be heard. We're not political in the usual sense. We're only political in that we're 100% against conflict. And any action that a government takes that appears designed to deprive people of their lives, their possibility to pursue lives, we as health people have to stand up and be counted. Now, that may sound very naive, but our voice needs to be heard.
Thank you, Michael. Anyone else like to pick up that response? Go ahead, Sudhvir.
Thanks, Roisin. I think it's distressing what's happening in the world. It's deeply alarming, and as Sir Michael says, we need to use our voice. If you go to the WHO website today, and I think WHO can and should do much more to call out some of these atrocities, but I encourage you to just go straight to who.int right now, and you'll see the entire page is covered with a headline saying people in Gaza are starving, sick and dying as the aid blockade continues. That's so, you know, we're certainly trying. It's not enough, and it's deeply distressing, but we just keep it up and not be afraid to call out what we're seeing.
Thank you. It's like we can all see what's happening and we can use our voices, but it's how we make the people that the decision makers, how we make them actually take action. And that's the really frustrating thing. I just feel so, yeah, strongly about this, because the images that we're seeing coming out of Gaza are horrific, absolutely horrific. And the world is just standing by. The leaders of the world, people like us aren't, but the leaders of the world are. And it's about that. Yeah, it just feels really, yeah, frustrating and heartbreaking.
Thank you, Roisin. I think you've spoken for many of us with those comments. Thanks, Michael and Sudhvir as well. I'll go next to Fiona Weir, and then after this, I'll pick up some questions with people who've put their hands up. Fiona, you raised a number of points. Would you like to choose to make one of them? Are you there, Fiona? Fiona Weir.
Sorry, here I am. I was talking, not unmuted. You asked me to talk a little bit about whether or not we needed to reintroduce statutory duties to involve in order to shift some of the power effectively. I it's a question that's been on my mind for a long time, since in the UK the statutory duty to involve was kind of abolished in 2011. I'm a disabled person, and I'm involved in disabled activism, and as well as being an independent researcher, and I'm increasingly coming to think that the lack of a statutory duty means that the voices are uneven, and public sector organisations think they are better at inclusion and tackling health inequalities than they actually are. The systemic barriers that are there are huge and looming, and directly experienced by people with lived experience, but often just not recognised. And when you tell statutory organisations about the barriers, that even when you've directly experienced them yourself, people don't believe you. And so for me, I'm increasingly thinking that making sure the voices are in the room, the only way of doing that is to introduce statutory duties, to make sure that the people who have the lived experience that highlights what's determining health inequalities are able to shout loud enough to be heard, and are not drowned out by the people in the services who think things are better than they are.
Excellent. Thank you very much, Fiona. So the issue is about reintroduction of a statutory responsibility, a responsibility for statutory services to involve people in delivery for services, policy making, and so on, as a way of addressing power imbalance. Jessica.
Just the elephant in the room is that in a context of shortage of money, which is the global situation now, engagement is becoming increasingly an optional extra, a luxury rather than a must-have, and it's a starting point for tackling health inequalities as far as I'm concerned.
Thanks, Fiona. Jessica.
Yeah, just to say I agree exactly, Fiona. This was highlighted to us very powerfully recently. We did a review of the impacts of racism on health in London, and there were 3 ways that we emphasised that racism affects health. One is directly, secondly through impacts on the social determinants of health, and thirdly through structural racism in service provision and delivery. And a lot of the recommendations that we made for challenging that were around strengthening the legislation, the regulatory frameworks, the equalities legislation, and in almost all the cases we found that it was too weak to be able to do what it said it was going to do, and what it said it was going to do was actually quite weak and relied on people to bring and represent themselves in a difficult circumstances, and to be proactive in bringing their cases up and so on. So we've, in that report, which was, as I say, is focused mainly on, in fact, exclusively on racism, we talked about the importance of anti-racism organisations, which went far further than the statutory obligations and were very proactive. So it's worth looking, I think, at some of the examples of organisations that have developed those very strong approaches. And I noticed a comment in the chat around DEI strategies and how they're being undermined and weakened or completely. Organisation seems to be jumping at the opportunity to get rid of them altogether. Our line in that report was that they're too weak. They need to go much further, and certainly not removing them altogether. So I think a rather roundabout way of saying, I totally agree. We need that representation. We need those voices. We need that co-production, and we need to strengthen regulatory and legislative frameworks and mechanisms for doing that, as well as the goodwill of organisations to go above and beyond.
Thank you very much, Jessica. If speakers want to respond, then do put your hand up and I'll come to you. Otherwise, we'll move on to the next question. Can I bring in Tanguy, who's raised a hand, to come on and ask that question? Tanguy Marega.
Thank you so much, and I really thank you, distinguished guests and delegates here present. It seems as if the resonating voice here is about action, but also addressing the challenges. And I've been connecting with the Marmot report since the first edition of 2010, and still up to now, it reverberates to the very kind of core of humanity in itself. I am in the specific area of mental health, and I'm campaigning for health equity, integrating into the formal diplomatic facets on the policy frameworks and everything. And it seems as if up until now, presently, we are sliding even further from governorship or governance issues. From what I think Jessica earlier said, action is actually missing and lacking. So I'm kindly asking those here present what sort of specific actions we might need to bring science and solidarity together, as we are hearing the voices actually sounding to the opposite of querying, asking the point of value of evidence, also challenging and questioning to a point of even questioning the objectivity of science in itself around diagnosis. The voices I hear right now, I'm getting paranoid about, is there is a lot of overdiagnosis about mental health issues, and yet mental health issues that are developing right now are actually an increasing epidemic of the underlying social policies and social determinants of health. I am honestly asking our voices to continue to be heard. I don't know whether it's something that we need to really focus our action on. Is there any avenues, if we were to be attending the World Health Assembly in itself, please guide me, and I think I could make my passionate point around a global health accord. Is this not the time for a global accord on mental health in itself, given its fragmentation right now?
Thank you very much, Tanga. There was a lot there. I think one of the points you were asking about specific actions on bringing together evidence, science and solidarity, and then that global accord on mental health as well. Could I invite one of our speakers to respond?
For what it's worth, there has been a movement. That there's the first global framework was on tobacco control, that there should be a global framework on health equity, on social determinants in health equity. And I think the leadership for that idea has come from Georgetown University. But it's an idea that I think needs more discussion because it would start to encompass the global framework on tobacco control, very important. To say that country after country will sign up to this. What if we had a global framework on health equity that country after country signed up? That would keep social determinants of health, the kind of things that this new report has emphasized, front and center. We should keep it on the table.
Thank you very much, Michael. I'll go next to, and thank you, Tanguy, for the questions.
Thank you.
And Bob Young, would you like to come on, Bob? Bob, are you there, Bob Young? If not, I'll move on to Jackie Peacock, and we can come back to you again, Bob, if you're having problems at the minute. Jackie.
Thanks very much. Yes, I really think that the formation of the health network is a hugely important step forward, but we need an even bigger voice. And my question really was, can we ever have health equity without wealth equity? Now, there are a number of organisations that are campaigning for more wealth equality, wealth taxes, etc. in the UK, and I know in other countries as well. Should the health network be looking to actually build links with other campaign groups that are all working towards a very similar aim that will have the potential for huge increases in health equality. I mean, if one of the reasons I'm sure we will know that the government is reluctant to be doing more in terms of health, and in terms of my own area, housing, that we've got a commitment to build 1.5 million new homes, which is terrific, but that is still going to be the minority of people, and the people we represent are in substandard, seriously substandard housing, and we need to make sure that there are funds available for that. So I do think the more people working towards social equality in all its aspects will strengthen our voice and have a joint campaign.
Excellent. Thank you very much, Jackie. Excellent questions about health equity and wealth equity and looking into housing there. Who would like to begin? Michael.
Well, Joseph Stiglitz, who's one of the world's great economists, and Jessica and I, in fact, have some connection because he's co-chair of the Council on Inequality, AIDS and Pandemics. I'm co-chairing it, Jessica's involved. His latest book, The Road to Freedom, which a title he chose deliberately. It's, in a sense, a riposte to Friedrich Hayek's The Road to Serfdom. And it's Joe Stiglitz providing an intellectual and an evidence base for saying neoliberalism is over. It's finished. It did what it could, and it brought with it great problems, and it's over. Now, that demise of neoliberalism has been, well, in a way, hastened and interrupted by the Trump administration, because they've replaced neoliberalism with crony capitalism, techno-libertarianism, whatever you want to call it. So, but it's not neoliberalism. You know, neoliberalism believes in free trade, not corruption. But there's a real intellectual evidence-based justification for saying the level of wealth inequality and income inequality in the world is damaging the world, not just leading to health inequity. And what Joe has done is laid out the intellectual framework. He calls it, whatever he calls it, new capitalism or something. I said, we call that social democracy in Europe. And he said, yeah, but I had to call it capitalism for my American audience. But it's giving us a strong evidence base for rallying around a different approach to organizing our affairs. And in its own way, this new report is supportive of that. And you know, it may sound like not enough, but the more we have voices coming from economics, from social policy, from health, that are talking a common language, the more chance we have of trying to deal with the issues that you've raised. And thank you for raising it.
Thank you, Michael. Jessica.
Yes, thank you so much, Jackie and Michael. Obviously, totally agree with what you're saying. Just though, we've been encouraging the local areas and the organisations that we work with to do what they can in spite of what's happening on that macro scale. We mustn't lose heart, and although we can't all individually influence the international financial system, Sudhvir maybe, the economic inequalities which we would like to address, there are still plenty of opportunities for action that we can do to mitigate the impacts, firstly, but also to challenge them. And collectively, of course, as I think you pointed out, there is space for us all to advocate for this. But even so, there are plenty of things which can help and do work to reduce health inequalities, even within that rather awful context.
Thank you very much, Jessica. It's great to see the chat, to see people making connections, which is what the network is all about. And someone did ask if we will publish the chat, because there's lots of useful stuff there. I think Jamaica did find a way of doing that previously, so we'll do that again with the recording on the slides as well. So we're on our last 9 minutes. Bob, are you there? Are you able to come on?
Yeah, thanks a lot. Very impressed with the report. It seems to me that if we're going to achieve progress, we need joint action on a common agenda, and that presupposes a consensus. But from where I'm sitting, I don't see that consensus. Most principal nation states see economic growth as the way forward. And of course, a key component of that is the production and sale of weapons. So inevitably, we're going to be facing more conflicts, I'm afraid. The debate between the supporters of donut economics, Kate Raworth's alternative to growth, that is less, doing more equitably with less, seems to me a somewhat distant objective at the moment. I've worked with developers, Chinese developers, Russians, Turkish developers, and it seems to me over the last 20 years there's been huge progress, which is reflected in the figures that were put up on the slides, that there's been a huge improvement in between nations, but within nations there has been a real problem. The creation of the new settlements beyond the Canal Ring in Moscow simply residualized the poor in the center of Moscow. The creation of the Marmaris cities around Istanbul has residualized the poor population of Istanbul. In southeastern China, the emptying of the megacities by the Blue Town Group and the Green Town Group has created a terrible gap now between rich and poor, and the healthy, the poorly and poor, and the wealthy and well, in that huge area of 200 million people in southern China. So we are heading in a particular direction. Governments are investing in improving the circumstances of their cities, but this is driving more inequality. And on top of that, you know, in this country, we've done great things in the UK in targeting the poorest people with the best quality accommodation through social housing. But what we now realize is that modern methods of construction and passive house standards have now imprisoned those people in buildings with awful air quality. Particulates and other aspects of atmospheric pollution within the home means that we're now creating new diseases for the poorest people in the best homes. It's ironic that this should have occurred, but there is very little assessment of air quality coupled with people's individual health circumstances.
It's a very important point, Bob. Can I just interrupt to bring back to the question, because we're running out of time a bit. Can I summarize your question and see if we can get a response? Because a really interesting point that you raised about there not being a consensus. I'll just go back to the first one that you made about the focus being on growth, and then you linked to donut economics as well. And I could see that in the report with Sudhvir's slides, you were looking at economic models as well. So could we have a response on that particular point about whether there's a consensus for health equity, whether in fact the consensus is more about economic growth and linking it to different economic models as a possible way forward? A challenging question. Who would like to pick that up?
I was waiting for Sudhvir to answer.
Sure, I can jump in. I think fundamental question yet again. I think you're very informed audience, as you would expect. So we think economic models are at the core of this. So the report talks about how some countries are looking more at well-being economies and the potential for that for health equity. Unfortunately, they're usually small, democracies and high-income countries. And so we want to see that model kind of walk the talk and be tested in all types of settings. I think, we also just must be a bit nuanced here, because I think for the poorest countries, we have seen that closure of the gap between countries. And I think part is due to some level of economic growth in the poorest countries. So we can't dismiss that. But then economic growth being the sole compass for society is obviously misplaced at the same time. So I think this is important, and I think the report kind of emphasizes that, but there's much more to do to get the right metrics and indicators. We're building on a parallel report that's been released called the Economics Council on Health for All, and that really puts forward the donut economy framework as something that's really critical to health. And so that's something that we very much look forward to taking forward as well.
Thank you, Sudhvir, and looking forward to that report too. We're into our last couple of minutes, and we have 3 questions still. I don't think we'll get through them all, but Amanda McIntyre, would you like to come on and make a succinct point or question? We'll get a response.
Thanks very much. Picking up on the point about how we help others to overcome their resistance to acting on the evidence. The most useful thing I've ever heard about this has come from Suzanne Zedek. And she has said that when people are struggling to act on the evidence, it's one thing to know the evidence, but it's another thing to think about how people feel about knowing that evidence. And it can really bring about very uncomfortable feelings of guilt, feelings of shame, and feelings of fear of chaos if I start to make those changes. Now, so Michael, in your response, you gave some really good strategies of how instinctively you are helping to break down those barriers. We've made some progress, so it's not all bad news. There's more to do. And also it's doable because we can break it down into things that can be done. But I think if we're thinking now about where those barriers are and how we could overcome them, where are the barriers? What would we say might be the barriers of guilt, the barriers of shame, and particularly the barriers of fear of chaos?
Thanks, Amanda. Michael?
Well, such good points. What I would say is if you look at, I'll put quote unquote, failures in democratic countries recently, I would say it was failures of the politicians to deal with the reality of people's lives, which is what I think you're saying, Amanda.
Absolutely. And they feel guilty and shamed that they haven't done it.
Whether it was Brexit in this country, Brexit tapped into real discontent. People lost jobs, lost livelihoods, they lost, but most of us who were for remaining were frustrated that the vote for leaving the European Union was based on real discontent with the wrong focus. Leaving the European Union wasn't going to deal with that problem. We had cynical, dishonest politicians. The same with the Trump vote. Real problems. Who voted for Trump? People in post-industrial communities. High rates of opioid addiction in those communities. So tapping into real discontent with people on the other side, as it were, not actually tapping into the reality of people's lives, quite apart from the issues that you're talking about of shame. We're not asking everybody to be an altruist. Certainly not. We want a polity that recognizes the reality of people's lives and gives everybody the opportunity to lead flourishing lives. That should be what we're trying to achieve. And to come back to what Jessica said, the communities that we're working with around the UK, I think we are tapping into that.
Excellent. I think that's a very good point at which to wrap up the webinar. Thank you very much, Michael. Thank you very much, Amanda, for that question. Thanks also to Dr. Sudhvir Singh from WHO for presenting today. That report is linked in the chat as well. I would encourage everybody to follow that up. Thanks very much to Drs. Jessica Allen and Antia Castedo. and of course to Sir Michael Marmot from IHE for joining us too. And that's all we have time for today. Thanks everyone for your contributions. The chat has been fantastic to follow. We will be publishing the chat and the slides and the recording of the webinar probably by this afternoon. Do join us on the last Thursday of the month when the webinar will actually be featuring 3 presentations from network members about the work that they've been doing across the UK. And today, thank you very much, all our speakers and all our participants. Have a good rest of the day. Thank you.